everyone. My name's Britt Guest.
And I'm Scott Kobner.
And welcome to May Emergency Grand Rounds.
It's a little bit of a sham though, Britt, because we're actually pre-recording this right now. We're actually in the past.
In the past, we're not here, but we are.
Yeah, so we have pre-recorded this month's Grand Rounds because EMRAP is actually moving to a new studio space. We got a lot of construction, a lot of lights, other things that'll be moving, but we didn't want to miss the opportunity to bring something great to you on YouTube and continue the tradition of Grand Rounds every single month. But we're not just kind of leaving people out there by themselves.
We're not leaving you alone, although maybe you would like to be left alone for 1 month, but we're still going to be here. We're going to be live in the chat answering all your questions. We're going to throw in polling questions, get you guys involved, see what you think about the case, and we're leaving you in great hands. We've got 4 new faces, 4 new faculty from USC. We've got Dr. Craig Torres-Ness, Emily Johnson, Mary Sheffers, and Alex Lee.
These are 4 docs that we've worked with for a really long time that have spent a lot of time working in a pretty intense community site in Los Angeles. And we picked them because tonight's going to be a little bit different, Britt. We're going to do one single case throughout the entire evening.
And it is a little different. This isn't our normal Grand Rounds, which is really exciting. So it's kind of a game. I know there's some dice involved. So Scott, maybe you could give us a little rundown of what this is going to look like.
Absolutely. Why don't we go over to the light board right now? I'll explain some of the rules and what you can expect for the entire show. So as Britt alluded to, for tonight's Grand Rounds, we're going to do something totally different. I'm a pretty huge nerd. I love playing tabletop RPGs. I love D&D. I love Dungeon World. I love coming together with a group of people to engage in a little bit of fantasy creative play that helps us solve problems and work through stories together. It's a really engaging and collaborative experience. And at the heart of it is this idea of collaborative storytelling, where some people come with an idea of what's about to transpire, other people come with their imagination, and together we all learn something. We actually do this in medicine quite often, except we call it something a lot lamer than D&D. We call it simulation. In fact, we have tabletop simulation and gamification, all of these things that have emerged over the last few years, really trying to bring that collaborative learning environment together to help us learn things that we can't easily look up in a book, like clinical decision making. So tonight we present to you our approach to tabletop simulation and calling it board certified. A little bit of D&D, a little bit of medicine, all sprinkled together to hopefully bring you something fun to watch and exciting to learn from. We're going to play some roles in this game, similar to how we set up a game of Dungeons and Dragons. In D&D, it's called being the Dungeon Master, but you're probably more familiar with the Sim Leader or the Sim Instructor. This is the person who actually knows the medical details of the case, and they're serving as both a narrator and referee, keeping the case on track, responding to all the players' inquiries, and as the one source of truth to sort of guide the story along. Then, of course, we have the players. We've got the people who are going to be not dwarves or elves or warriors of some kind, but playing community doctors in a fictitious community hospital setting and working through the problems as they would work through them on any given shift. They're going to have to discover answers and work together in order to help the patient. Now for tonight, I'll be playing the role of the evil and despicable Dungeon Master, and these amazing faculty are putting themselves in a pretty crazy and vulnerable space to be players in this game. They have no idea what the details of this case are. They've learned about the rules 5 minutes before the camera started rolling, and they're going to be demonstrating to you in real time how they might think through this series of problems, the questions they'll ask, and the responses to the therapies that they've given, just as they would on any given shift. I think it's also important to let you know that the cases that we're going to be doing are adapted from real-world cases with real clinical information and data that are going to be fed to these players in real time. So you'll get to see exactly how these decisions might transpire. But it's way easier if everything plays out according to plan. And in medicine, we know that things don't always turn out how we expect. So sort of the paradigm for the night is going to be me describing what people see, hear, feel, kind of like an oral board situation. The team is going to decide what they want to do with that information. And at critical moments, we're going to introduce an element of chance, an element of uncertainty, the real magic of medicine, where we don't really know what to expect. We're going to ask our players to roll dice to help us decide what happens next when things are not entirely clear. When they roll the dice, they'll have a few options for results, and you'll see them kind of appear on screen. If they have a low roll between a 2 to 6, whatever they tried to do, they failed at, and they have to move on to another option. If they roll a 7 to 9, they succeed, but at a cost. They might get the thing accomplished, but something else comes up later on that's a price they have to pay. And if they roll a 10 to 12, they have a perfect success, and they can move on knowing that whatever they did it as intention. Here's an example. Let's say we're trying to intubate somebody. And if someone rolls a 2 to a 6, they're going to place the tube and a volcano of emesis comes out of the patient's mouth. And now they have to deal with this problem of failure. Maybe they rolled a 7 to 9 and they're able to get a great view, but they're not able to pass the tube through the cords. And on a 10 to a 12, in this example, they were able to nail it. They got the tube through the cords, high fives all around. So in this evening's activities, you're gonna see us call for these dice rolls pretty regularly in those moments of uncertainty. I don't know what the rolls are gonna be. The players don't know what they're gonna be. And on the spot, I'm going to adapt with them in this collaborative storytelling exercise to sort of resemble what you might encounter on a given shift. This case is really challenging tonight. Again, it's based on a real scenario that we've encountered. And we really hope that you learn from the clinical decision making and see how this process unfolds in real time with your colleagues and peers in a way that is totally unstructured. We hope you enjoy Board Certified.
We start our evening on your first night shift of a new locums job at a small community hospital called Norman Percy General. It's a hospital that serves a diverse and vibrant patient population in an area of the city known affectionately as the Bluff because it sits atop a large hill. It's a very busy small emergency department because it turns out you're really the only hospital left in this side of the town. All the other hospitals have closed up after venture capitalists and private equity firms discovered it was far more profitable to harvest the souls of people suffering and sell them for cryptocurrency rather than to actually help them. In fact, the nearest hospital to you is the only academic center of the city, the High Billings University Center, but most people call it Amazon General after it was bought out by a generous donation from Jeff Bezos. You've never worked at this hospital before. It's your first shift, and you look up as you're getting off the bus right outside. It's pouring raining, and you finally learn why the hospital gets its nickname from its patients. Some of the red neon letters on the sign have gone out over the years, so now it reads, "No Mercy." You walk in for your single coverage shift, and you're entirely responsible for a 50-bed emergency department, relying on your nurses to help triage some of the patients. A senior nurse, who you reason probably started his first shift the day the foundation for the hospital was poured, approaches you. He tells you there are 3 new patients to be seen, and you only have 1 open booth. He asks you which you would like to see first.
There seems to be somebody who has like an ankle sprain, he thinks, is like a 12-year-old who is running playing soccer. A 31-year-old guy who has asthma and seems like he thinks just like a mild asthma exacerbation. And then there's a really weird dude with a rash who keeps talking to himself, who he was just gonna have sit in the waiting room until it kind of fixed itself. Who wants to know which one you guys want to bring back?
Ooh.
Sounds like maybe the asthma
Yeah.
person.
I feel like the answer is the rash, but
Yeah,
I think
for
I want
sure.
the asthma guy.
Yeah, no trick questions. The asthma person comes on back and gets a booth. You get quickly taken away because there's a patient that needs a central line that was signed out to you, of course, that's about to go to the ICU. And so the nurses say, we'll hook him up to the monitor and we'll give him a neb, call RT for you. And so about 10 or 15 minutes go by, you get back to finally see the patient. And he walked in, was brought in by EMS. And he's a 31-year-old guy who's coming for shortness of breath for the past 2 days. You look at his chart, and the nurse wrote his history of morbid obesity, obstructive sleep apnea, and he's had this asthma from childhood, supposedly. You look at him real quick before you start talking to him, and he's probably the biggest human being you've ever seen in your life. You imagine if he stood up, he's like 6'3", easily, looks like a linebacker, weighs probably a cool 380 pounds. And you have a hard time. He's wearing a really nice polo shirt, but it makes it indistinguishable from where his head ends and the rest of his body begins. He doesn't seem to have a neck at all. And he's sitting up holding what looks to be like the smallest possible nebulizer in the world compared to the stature of this man, just breathing in and out some albuterol that the nurses started. What do you guys want to do?
I think I know where this case is going.
I mean, maybe at least you could put him on some BiPAP to kind of help get that neb sort of into a system. He's already kind of an obstructive guy, might need a little positive pressure.
Okay.
Yeah.
So you like to call RT, get BiPAP on the way?
Yeah, we can do a little exam, take a listen.
Cool. Okay. He's fully alert and can talk to you and stuff too and give you some more history. So you quickly take a listen to his lungs and you really turn in, give us a roll, see what you hear, EJ.
Oh, yeah. So I'm one of those fancy digital stethoscopes. All right, I got a 5.
Got a 5. You put it on, and you hear absolutely nothing. Like you've even taken the guy's shirt off. You're doing, like thinking about tactile fremitus. But you think even if you had like a really fancy digital stethoscope, you're auscultating through a very large person. But it looks like he is moving air. He's breathing in and out. The nebulizer's puffing. So you're not worried the absence of breath sounds is because he's just not moving anything. You just think you can't hear anything.
Then I like to have the patient tell me if they feel like this feels like their similar asthma flares. How often have they been using the albuterol at home? Any sort of red flags in terms of this is different, or they have a pretty extensive history of needing intubations or needing admissions, just to sort of risk stratify since the pulmonary exam's limited on this guy. And it sounds like you can talk, so hopefully you can give us some answers.
Sure.
Yeah.
You start asking some of these questions. He's actually there with his father, who's like an elderly dude. He's like around 70, is not as large in stature and size. And he actually quickly butts in and he says that, he's had asthma since he was a child. So it's been a really long time, and he's concerned also that he's getting sick because the patient's like 4-year-old daughter at home just got this terrible URI, with coughing and sneezing all over the place. Then the patient starts to talk to you, and it's the most bone-chilling sound you've ever heard in your entire life because he sounds worse than Kermit the Frog. And he's just like, for a month. And then he goes back to breathing on his nebulizer. But he really looks cool and calm while he's talking to you. It's like very jarring by like the voice that you hear and how comfortable he kind of looks.
And is he having a sore throat? Is he having difficulty tolerating his oral secretions? Is he drooling, anything like that?
Yeah, he says to you, no, I'm running nose and a fever.
Okay. And do you always sound like this when you talk?
What do you mean? And his father's like, sometimes when he gets sick, sometimes.
I would also probably look for like secondary signs in terms of like a respiratory exam, like your IDE ratio and how much like tachypnea in general, I would say.
How about some
and
vital
then like
signs?
any some like vital signs. Is he like sitting forward? Is he using his sternocleidomastoids? Is there stridor when you listen over his neck? And what else? Oh, also for his size, I would make sure RT usually puts like the baby 2.5 milligram dose of albuterol in there, and I would say go ahead and put 15 or 20 in there and keep it going while I'm trying to figure out whether it's his upper or lower, I guess.
Sure, absolutely. RT comes by and like he unscrews it for RT, and it's like a giant opening up this like small container, and they put the more albuterol in, and it looks like he's breathing equal I to E, but they're both pretty prolonged, and he's breathing about 20 a minute, and you can't see if he's using any accessory muscle use. He's kind of a little bit tripoding, but to be honest with you, like he's so much bigger than the bed, there's not really much to lean on. And he's sitting with his feet over the edge of the bed, just sitting up. So you think that's kind of tripoding-ish for him. His vitals are the ones that you see on the screen. So his heart rate's 92. He's satting 94% on your nebulizer. Blood pressure's 142 over 96. And that's basically where he's at. He looks pretty comfortable. What's the next thing you want to listen for a stridor, right? That was the other thing you were interested in. He doesn't really seem to make any audible stridor when you put your stethoscope up or if you get kind of close in there, but it's just that voice change that he has.
I mean, so at this point, I'm still concerned for what sounds like more upper airway, which at the same time, given his history, I'm going to sort of be treating both. And I think for him, one thing I want to do is get steroids on board early. It's going to be sort of effectively treating both. I like the idea of BiPAP, just kind of maximizing the treatment with minimal sort of downside at this point, especially given the fact that I want to do everything I can to not even get close to needing to intubate this guy if he were to go that way. And then also, I may have missed it. What am I seeing in his mouth?
Yeah, we haven't looked at his
Oh.
mouth yet.
Yeah, so you open his mouth and you see a whole bunch of tongue, essentially, and there's just like a little hint of a uvula back. We don't see any large, like no deviation, no large mass, anything else in there. He's got great breath, great teeth.
And nothing beneath his chin, the floor of his mouth, everything?
You're palpating, but to be honest with you, there's no chin that you can discern. It truly goes like straight into his chest.
Okay.
Do we get a temperature?
Yeah, he is afebrile.
Okay.
Is his father still around?
His father's just hanging out there in the room reading the paper. It's like, this is just exactly what happened. He went to the hospital about a month ago for a coli, And he went in the same day and then was in the ICU for like over a week. They had a really hard time, I guess, like after the surgery. He had some trouble.
Getting him off the bed.
Yeah, extubating him.
Nice.
That was about how long ago?
That was like over a month ago.
Okay.
So there's going to be some subglottic stenosis.
Yeah.
Funny, the last time when someone was dying, there was a lot more laughter. Here we're like, oh my God.
This guy's terrifying.
Yeah.
Okay, so
How's
I
that
feel
rash
like
in the waiting room?
I feel like yeah.
I put the chart back.
I'm gonna leave this one to Craig. Or there's something else I need to say over there.
New one in room 2.
So I think what at this point I know with this voice change, I think it's so very true that people who have a lot of extra adipose tissue and tonsils can actually sound very weird a lot of the time. And so I think to make sure that I know if this is something like a 4-alarm fire or not, I would probably get a fiber optic. I would take a look. I would like do a video fiber optic scope.
I'm also pushing the patient and his father at this point. Like, listen, the thing that's most concerning for me right now is how you sound when you talk. And I need to know, is this a new or different voice change that you're having, or this is how you always are, and when you get asthma flares, it gets a little bit worse? Yeah. Because that, to me, right now is my big branch point, and I'm kind of trying to stress that to the patient and the family member, just being fully transparent about where I am in my decision-making process.
Sure.
So any like hint as to like the acuity of this Kermit the Frog voice?
Yeah. The grandfather goes to answer the question for him. And he says, when he gets sick and gets cold, this sometimes happens. Like he sounds different, but like we've heard this before. So it's not like a crazy change that's happened. Like, that's just how Earl is sometimes, has this weird voice. Weird voice Earl coming in. And so they're not as concerned about it as you'd expect. He looks pretty comfortable again, and he said he's really just having a hard time catching his breath.
I mean, I'm reassured by that. Like how comfortable he looks, he's febrile. They're not particularly alarmed at what's going on up here, and they're calling it asthma, and it sounds like he has exposure to a URI. Maybe he's got a little bit of pharyngitis on top of it. So I think I'm doing exactly what you said. I'm treating the asthma like I would, and then trying to get a little bit, contemplate maybe doing some direct visualization if I think that's going to be, because really you're just looking to see if he's got posterior pharynx edema. But that's also such a.
I mean, I think you got to be ready to take the airway upon doing that. So I think you're.
You have to have a tube.
Yeah. I think that's in the back of my mind is like, okay, I'm going to get everything ready, and then when I take a look, I'll be ready to intubate if I have to. I mean, knowing that he likely has subglottic stenosis, it doesn't even matter if I can get the tube. It's like, I think that too, in terms of like picking a small tube. And what else was I going to say? I mean, chest x-ray, ultrasound, to see if there's anything else like, does the chest x-ray look like hyperinflate? Is there anything, obviously with this guy, it's going to be hard to hyperinflate.
Sure, okay. We can get a chest x-ray coming in. Any other labs, any other stuff like that?
Yeah, I mean, I get a full set of labs like BNP, troponin too, and then you have to kind of, if you're going to be systematic about this, the history definitely helps you, rule out maybe some things like angioedema. It doesn't sound like this is sort of, it seems like it's triggered by a URI. You look around, maybe hopefully you're ruling out like anaphylaxis and just sort of like dotting those I's and crossing the T's as you're kind of working them up. And then, I think ultrasounds, I would definitely do that and look if he has like overload, lower extremity swelling, one leg bigger than the other. So, it's a big guy. It doesn't sound like he's running marathons, so maybe he's sitting around a lot, and that's a risk factor, kind of soft call for DVT. So I'd kind of be going in that direction too.
Yeah, the blood gas.
EKG.
Yeah, just a
blood gas,
trend,
sure. Totally.
more so than like make a clinical decision at this moment.
Sure. Okay. So the nurses take forever to try to get access on them. In fact, it's like really difficult, and they have like a 24 gauge in the hand that they're able to get for you. They're able to draw some labs off, as well as get an X-ray for you. It's the first thing that comes into the room. Tech rolls in and gets this image. What do you guys think?
Looks like asthma. I feel like there's some bronchial cuffing, maybe. Little spots everywhere, right?
Does this look like it's narrowing there for you?
At the
Where are
top,
you guys looking right now? At the top?
At the top.
trachea,
The lungs look like they
Lungs
look
look
like
fine,
typical
heart
asthma
looks
lungs,
fine,
but
yeah.
above does look like it might taper off a little bit in the trachea. Yeah.
Okay.
Anything over the neck, like a little scar, indent?
Nope, he's got nothing that you can see on your exam. You guys are okay with the X-ray?
Yeah, I think
Okay, so
Alex is totally right. It's
Final
like there's-
impression is lungs look fine, heart looks fine, correlate clinically.
Check.
Yeah, great.
You guys are so
And
tense
is he
about
having?
this,
Is he,
guys.
I know. Is he
We're all
having Strider?
anticipating.
What?
Is he? I feel like I keep missing these physical exam findings.
We
Is
can't
he having?
tell. The answer is nothing in the
I
exam.
got
We
it.
can't tell
All
anything.
right.
So we're
All right.
like, no, I think that's the part of it, which is maybe we just need to look.
Yeah.
Just want to
Everything we
clarify
try.
something. So how long has this been going on for?
This has been going on for 2 days.
And in the past 2 days, has his voice progressively gotten worse, or has it been, since onset, pretty much the same?
I mean, his dad says he gets like this when he gets sick, but
Sure.
it's worse today than it was yesterday.
right.
But like,
Okay.
that's Earl's thing, man.
Yeah.
Good old Kermit the Frog Earl.
I mean, I'm not thrilled about doing fiber optics on this guy.
Yeah, me neither.
At this
That's why
point,
I
because he
asked,
seems
yeah.
like he's not an extremist, and I feel like it's going to only precipitate him becoming in extremis, even if he's just like
Spasming,
fighting
yeah.
from having this thing shoved up his nose, and then it's gonna make us play our own card there.
I would definitely give rack epi.
Yeah, that's what. Yeah, so I'm
And
treating
look at
symptomatically, and I'm
steroids.
even thinking if imaging this guy's neck would help.
I don't know. I want to lay him
I
flat
know.
on the-
Yeah,
That's
he's
right.
probably too big for the scanner, actually.
Yeah.
Oh,
340,
380,
yeah.
500
Depending.
pounds.
Depending how tall he is.
Yeah,
Yeah.
depending on how tall or how big his chest is. I definitely had a patient that couldn't get his chest in.
Yeah,
gotta get the neck
rack
in.
epi plus steroids on board, and see what he's doing clinically.
Yeah, all right, so you get that on board. The steroids are already in. Got rack epi, rock and rolling, and then that first VBG comes back. This is what you have. He's like, when you look at him in bed right now, he's still using the little nebulizer. You got BiPAP at the bedside. You asked for that before. And he's like, tripod a little bit that you think. Again, he's got like, it looks like he's smoking a pipe. He's got the nebulizer in one hand and he's got his arm on the other leg. This is VBG. What do we think?
Well, the CO2 is 84 with a little bit of an elevated bicarb, which just tells you that he probably lives somewhere that's higher than our normal, but not 84. And then the pH is obviously 7.1. So there's obviously some respiratory acidosis happening, but there is some baseline. That's kind of what I would say.
Which is what I would expect, like a little
Yeah,
acute on
exactly.
chronic respiratory
Yeah.
acidosis.
Little Pickwickian situation.
Okay.
of sorts.
I'm not going to make too much of the lactate because of the albuterol that he's been on. And
Sure.
Cool.
Yeah.
And to me, this is going to be helpful if, like, in an hour,
Yep.
I'm
If he's
gonna-
better in an
yeah,
hour, totally. Yeah.
So is that your guys' plan? Have some stuff ready at the bedside. We'll cycle back in an hour, let some labs cook, see the guy with a rash in the waiting room, and just let this guy with Kermit the Frog voice just hang out. And
I mean, I would put him on BiPAP though, right? We're in
Yeah, he's
agreement
on
that?
BiPAP,
You
right?
guys are gonna
No,
put him
it's
on
at the
BiPAP?
bed.
Okay.
It's at the bedside, but I
I
think I'd
with
pull
that
the trigger
CO2
now.
there, I would. I feel like that's kind of the only thing you can do to fix that is not tell the patient to breathe faster, but do a
Yeah.
little bit more pipe. Yeah,
better than
pipe.
ventilation.
You get him on BiPAP, and he's just like, "This is like my mask for home," and he puts it on. Just don't even have to coach him. He's a champ. You'll see some other patients expecting kind of frantically the nurse is going to come running and find you, and it's going to be the worst 5 seconds of your life, but it doesn't happen.
Okay.
Some of those labs that you sent off come back. So his CBC and BMP that you sent come back. His trope is negative. His BNP is also negative.
Okay.
And his O2 sats on BiPAP and everything, is he like able to maintain? Are we able to correct the hypoxia?
He's going from like 93 to 95%. That's where he's at. You go back to reassess him. He's been on the BiPAP now. I got some rack epi, and now he's actually laid back in the bed with a mask on, and he's just kind of like looking up. But you call out his name, and he just like perks up, and he like waves at you. He's a really nice guy, just like a lovely gentleman.
Of course.
You get there's the first
Another VBG.
VBG for comparison. You guys asked for a
Yeah.
second one about an hour later, and so here's the next VBG.
Dang.
All right. Well, the ship has sailed
Yeah.
in terms of
7.0 to 108. Okay, got it.
This man needs an invasive airway.
I think he does. I mean, so at this point, as you're preparing, like I think whether it's nasotracheal or orotracheal, whichever way, I think that's sort of like the discussion you have in your head, and then whether you need someone to be back up for you, either another ER doc. I would probably not knowing this place, see if there's someone else in the house who could come to help if that was necessary.
Who else would you guys want to come help if you had your choice of the litter?
I guess it is Monday.
It's Monday. It's
true.
Banker's hours.
Yeah.
The intensivist and/or anesthesia.
Okay. So intensivist, anesthesia.
Yeah.
Anybody else be on your
ENT
list?
would be another
Yeah.
option if
ENT?
you don't have them.
Surgery.
Surgery. All right.
Yeah.
Why don't you each roll a die? Let's see what our consultants are up to today.
Right.
All right. So starting with Craig. What do
I
you
got 10.
Okay.
I want anesthesia.
You got 10. So anesthesia's in-house today.
Okay.
They're doing an elective Brazilian butt lift right now in the OR. So they're in the OR in a case, but they are around.
Okay.
What did we get, EJ?
I got an 8 and I would like surgery.
Got an 8 and you would like surgery. That's wonderful. That is who's performing the Brazilian butt lift. Their surgery's up there. Unfortunately, it's Dr. Grunning today, who's like not the nicest person to deal with. You've only consulted him one time for appendicitis, and it took him 20 hours to get back to you, unfortunately. But that's who's in. They're here. They're in house. All right. What do we got, Alex?
I got a 9.
Got a 9.
I'll take ENT then.
Get ENT. ENT, luckily, the local golf links is not too far away. It's only about an hour and a half drive. But they're available by phone, and they also have a really nice iPad that can access the EMR and look at anything they want from there, including the patient's insurance status to see if they're going to come in and help you.
So typical.
So not coming in.
Poem Crick Hair, what did you roll?
5.
5. Well, of course, there's an intensivist in the house. Dr. Sterling is 87 years old. He's been an intensivist since the time of the birth of critical care. He's fallen asleep many a time during your sign-outs, but he's like, oh yes, I'll come right down and give you help. So he's there for you if you need him. So that's the team that you have. So you're making the decision to intubate this guy now. You're 100% committed. Is the whole team on board?
Yeah.
I mean, I think so. Especially because he's going in the wrong direction, and you really don't want this to be a crash airway.
The only other thing I might do, I guess one thing to think about is like, he's at least arousable and awake, so you can slow playlist to the extent you can make it as absolutely safe as possible. And I would also just make sure that I'm not missing anything. So, I would, while someone's getting at least 2 lines of access, I would pull up an ultrasound and finally do that, cardiopulmonary exam just to make sure this isn't something that could be reversed with a little bit of nitro, just to dot those I's.
Sure. All right, you do an ultrasound real quick. You got good lungs sliding bilaterally, no B lines. Getting that cardiac view is really, really challenging. You're at like the max depth, but you don't see an effusion. Everything actually looks pretty good. He's got good squeeze. The ventricles look kind of equal in size, but there's nothing that jumps out at you.
All right.
So how do you want to do this?
I mean, and before we intubate too, I feel like the one thing we've sort of skipped over is how much we try and avoid intubating asthmatics. But for him, we're like, oh shit, that's a terrible airway. And then we jumped straight to that. So I'm making sure that he's gotten his 3 duonebs. He has 20 milligrams of albuterol cooking in that BiPAP inline the whole time. He's gotten his steroids. He's gotten MAG. Because I still don't know if this is upper or asthma, but I'm at least making sure that he's getting all of those treatments because
Plus
it seems
maybe
like
some epi. I mean,
yeah,
not
exactly.
rapid,
And that's
but
the
like
question
real
too is
epi, yeah.
epi, which if I
Give
have
him a
access, I
little
probably can give him a
EpiPen or
little bit
something.
as
Yeah.
well.
Great, yeah, you can give him epi.
Just to wake him up.
Yeah.
Give him all that stuff.
Just try your best, yeah.
You get him going. He looks a little bit more jazzed.
All right, now we're like,
really
all right, man, we're gonna put you back down.
He actually does look a little bit better in the bed. Now you got him on epi. You've given all those things, but it sounds like you guys are considering intubating him not because he's an asthmatic. You seem to be more concerned more about his airway. Is that fair to say, or what's the thought process here?
Both. He's not ventilating well, right? And so he's becoming more acidemic. This isn't going in a good direction, and I would hesitate to send a guy with some upper airway concerns to literally anywhere other than the ED. So
Okay.
Also, this guy we put on BiPAP who's tachypnic with shortness of breath is sleeping when you come in to reassess him on BiPAP.
He was up late last night. He was
Sleeping and knocked
sleeping
out.
in his 4-year-old.
yeah.
Yeah.
I know, for the fact that the BiPAP, like he's just like getting much worse before your eyes, and whether that's because you were able to raise his oxygen enough that he's like now no longer got the drive to like breathe as much, but the BiPAP does not seem to be helping. And I feel like you're a little bit, the only thing that's going to happen is he can get more and more sleepy, and then his airway is going to get more and more kind of collapsed as he gets more sleepy, I think.
All right. Well, how are you preparing to intubate this guy? You got RT. You said you wanted a fiber optic scope potentially brought down. They looked everywhere for one. They dusted it off. No one's ever used it in the hospital before.
I don't know. I mean, I think I'd have like everything. So I would have, if I had a VL, I was going to say DL, VL that is like a rigid scope, because I think with a lot of tissue, rigid scopes are really helpful. I would consider ketamine with like, just look in there with a rigid scope and try to intubate, because that's what you do all the time, versus having that with the fiber optic, right? To get, in that one, if I were going to do fiber optic, I think I've done it both ways. I think the nasopharyngeal approach is definitely better in terms of the view you have and how easy it is But I would probably be prepping him with, Lido, atomized Lido and Lido jelly to make sure that however we had to go in with the fiber optic, he'd be numb enough to do it with a little ketamine while he's awake. Because I think, I don't know, maybe I'm jumping the gun, but I think we're awake intubating him.
Yeah.
Yeah,
For sure.
sitting him
Hands
up, ketamine, and then pre-oxygenating with the BiPAP, throwing in some nebulized lidocaine in there as well, plus or minus the jelly. I've done enough fiber optics that it's definitely an option, but I also, in this guy, like the ability to use the VL with the rigid stylet and with a smaller tube, and to being able to kind of get as close to that epiglottis as possible, and then if I need to push through any subglottic stenosis. And then sometimes, it's kind of hard with one person, but using that fiber optics as a drivable bougie is another option. Because I anticipate the sort of twofold issue is getting the look behind the tongue, which I think that the hyperangulated is good for. And then once I visualize chords, getting past any type of subglottic stenosis is my second anticipated issue. And so the fiber optic I think is going to be helpful in that regard. So maybe using it as like a drivable bougie, but ready to go with the bougie and the hyperangulated I think is going to probably be my, and the rigid styletter is going to be like my start. And then if it's a surgical neck, it's going to be a nightmare, but also obviously prepping the neck and maybe taking a quick peek at his anatomy beforehand.
Telling him probably, you've had all this prolonged intubation, there is this risk, and make sure that he's sort of mentally ready for that.
Yeah.
Sure.
Yeah.
And maybe asking whoever that intensivist is if he knew him, or in terms of like anything that he had learned on his intubation or extubation that could be helpful, or if you have a colleague that has seen this patient before.
Yeah. Do we have nasopharyngeal tubes?
You do. You have the smallest tube size you have for nasopharyngeal 6.5, the nasal ray, and then the smallest tube size that you have is a 5.0 for a regular ET tube.
Okay.
You talk to the intensivist, you give him a call, and he's like, oh, great. I remember him. Yes, yeah, he has the COPD. He clearly has no idea who the patient is, but he's really eager to have a new friend in the hospital.
I know the guy.
Come on.
You won't be down there? You won't be at the bedside?
We do, but do we?
The other thing obviously with a guy like this is positioning him. So I think we have to decide what we're going to do first, whether we're going to do the nasopharyngeal or do the glide scope basically, because the positioning is totally different and we're going to have to be able to switch from one to the other depending on which one, if one works. So I think if we start with the nasopharyngeal, we have to know okay, if this isn't working, then what's the series of movements into getting him into position to intubate.
Yeah, exactly. Both you and him.
Yes.
You're going to have to go from the front of him to the
front of the bed
back
to the back of the bed. And then I think with people who are super heavy, we end up putting them in 45-degree angles, but then their belly is so big that it you literally their body won't move and you can't ventilate them because their belly is making their body be in a weird position. So I usually will put them in reverse Trendelenburg so that they're flat but up. And so just to have that prepped, or have that at least as the plan for everyone to know of what's going to happen.
So the patient and his dad have been just going like this, watching you guys talk in the room. He's awake.
Oh God, that's the worst. Is when they're looking at you, you're like, really? Is this really necessary? You're like, I don't know.
I know, right?
I hope so. I don't know.
But you explain the risks to him and what you're worried about, and he's like, and gives you kind of like a thumbs up. But to you, it's almost like the end of T2 with the thumbs going into the lava. Thumbs up. It's not a very exciting one, but he's down to be intubated if you guys think it's necessary. So what's your plan A? What's your plan B? What's your plan C? And we're going to go for it.
In my head, I'm like, this is a person where you want to go with the thing that you are absolutely the most comfortable doing, because you're going to have a guy with no reserve who's got a big, heavy chest, and you're going to have to think and move really quickly. And so for me, that is probably just rigid video with bougie backup to go through. But that could be different for everybody, I think.
I agree with that. I'm gonna put him at 45 degrees. I'm gonna give him ketamine so he's awake and breathing on his own. And I'm going to use video hyperangulated with a rigid stylet, with the backup bougie, with my fiber optic scope fired up, with it already lubed. And using that as if I get a look posterior and it's a mess and I realize that that's my limiting factor, then I'm gonna, at that point, while he's still awake on ketamine sitting upright, move over to the fiber optic while he's still breathing.
Yeah, I think that's probably the right thing. I mean, especially because while he has his voice, maybe this is how he always is, maybe not, but the subglottic stenosis is there regardless of whatever is happening higher than that. And then so maybe just being able to have the smallest tube with the rigid scope is the best way to start. I
Yeah.
feel like I could go either way.
Yeah, I think Emily nailed it. You have to do what you're most comfortable with. How many fiber optic scopes do we do into the back of the throat? I mean, not that many. We can debate a lot more than that. So a Bridget Stylet video.
I honestly thought when you were saying that you were about to be DL, baby.
Yeah.
Oh man,
Digital
I'll put a-
integration.
I'm not that big of a
Put a
cowboy.
C-collar on him and I'm going to DL him.
Retro.
All right.
All right.
Cool.
You got all that stuff set up. What med? So you want to give ketamine first. You're going to do video laryngoscopy with a rigid. Taking a look. What do you want to give him? How much ketamine?
We have an IV, right? This
You have
is
an IV. You
obviously
got 2 points of
not-
access. Now you know you guys have been in there
Fluids,
having like the
epi.
meeting of the minds for like
Yeah.
an hour.
Everything's
Honestly,
going.
you can repeat a VBG at this point. There'll probably be a change. So you got all the stuff you need at the bedside. How much you want to give?
And I'm going to go procedural sedation dose on this guy because I don't want him fighting and bucking it. And he's so big. But granted, I'm probably not going to. I'm going to give him probably IV 150 milligrams of ketamine.
I think I'll start with
It's like I'm not going to go full 1 mg per kg on this guy who's like 380 pounds, but I'm also not going to just do a little tiny subdissociative dose where he's like awake and kind of just like a little bit out of it because I need to optimize my view and I need him to be in the perfect position without paralyzing him totally sedating him.
All right.
And then I'm also then we have I have labs back maybe on this guy. Yeah, his K was okay.
Okay.
And then sucks ready to go.
Yeah.
Yeah, I also think, so we would have probably like a nasal cannula going at like 15 or whatever, just so that when you're looking, you have a little bit of oxygenation. Hopefully having him in that position, like the reverse Trendelenburg or whatever, such that he's not retaining so much while you're looking, like he's maybe not going to decompensate as much. And then, I mean, I'm trying to think of what I would, I don't know.
The
I
guy's
guess-
father is like looking at you. It's like last doctor wasn't like stroking their chin for like an hour.
Here I am, I got my
confidence.
I've got my
We're more
prayer
cerebral.
hands going.
Yeah.
Yeah, no, I think that's it. I think we're,
All right.
I mean, the other thing I would think about is like if you're making the decision that you have to intubate this guy, sucks is kind of risky because if you end up having to cut into his neck, so maybe have Rock like ready to go because if you're going to have to go for a surgical airway, you want this guy like out and flat and not moving on you.
Yeah, that's true.
yeah. Yeah, I think that's true. I think Rock is a good, and you just plan to push it as you get it in the airway.
Why don't you roll for pushing ketamine? Let's see what it does to him. 150 milligrams IV.
3.
Great. So you push
Okay,
the ketamine.
so push ketamine, all right?
You're coaching him. You're like, think happy thoughts. You're
Yeah.
on the beach. You're with the rest of the Muppets. It's really great. It's fun. And then he just starts leaning back and looking out at you, and he turns to you, and you just see the nystagmus start beating, and he's like, just like making this terrible groaning noise. And that's how he looks at you.
All right. But he's breathing.
He's breathing, but he's making this, and the dad who's like outside is like, what is going on? It's
All
like
right.
an exorcism in the room.
All right, so he's still breathing. So at this point, I'm just gonna sit there. I'm gonna position him. I'm gonna give him some jaw thrust. I'm gonna help get all of that up as much as I can while keeping him at this 45-degree angle. And I have RT there ready to back him. I'm probably potentially gonna need to start supporting his breast, but I'm kind of taking a look at his vital signs. So with this like jaw thrust, giving some pressure back here, is he like still in this sort of, is he still breathing? I mean,
He's breathing.
Yeah.
It's just very clear he's not having a good time. He's in like
Yeah.
that no man's land between being fully sedated and, you know, just getting some pain dose of ketamine right now.
I know. I'm
breathing
holding in that
irregularly.
position right now. Then I'm just kind of seeing what's going to happen. Like, which way is he going to take this ketamine? Do I need to give him a little bit more ketamine to get him through it, or is this guy going to make this even more difficult?
Okay, roll the die.
Okay.
You're holding him out.
I mean, I have a 7.
7. So he starts to calm down a little bit.
Okay.
And he's like getting a little bit more loose, but still the eyes like roving, and he's got that expression of horror on his face. And his breaths have slowed down a little bit now, actually.
right.
He's now breathing at like 14 when he used to be breathing at like 24.
Okay. So at this point, I'm going to just pull the trigger and take a look. I've ideally premedicated with an antiemetic as well. I've got some.
Back in time.
Yeah. During our
Just like
conversation.
you can in real life.
And then I've got some Surgilube on the hyperangulate, so it slides as well as it can over that tongue. And then at least, even if he starts to wake up or starts bucking this, I can get at least a view to see what's going on posteriorly. So I'm just doing that mostly to kind of at least rule that out or rule it in. So I'm sliding that through, getting to the back of the tongue and getting a view.
Sure. Okay. And at this point, you guys hadn't given like the lidocaine, or did you want to do that with the antiemetic and all the other stuff that happened before?
I think we're
Rewind.
We just
Just kidding. Okay. EJ, why don't you roll? You guys are sliding back, trying to get a view.
suctioning. I get a 8.
We're getting better.
You look in, it's like the world's best view of the cords ever. I'm just kidding, of course not. You get in there, and it's really hard to move the tongue out of the way. The camera is getting all fogged up. There's some secretions, but you do see the cords, and you've got like a grade like 3 kind of view. They're very, very far away and anterior, but you can see them.
All right.
And his vitals right now are still looking okay.
Okay.
He's statting 92% now on just blow by nasal cannula you guys set him up on, and he's breathing at like 12 spontaneously still.
Get that tube in that
Yeah.
hole.
I mean, at this point, I'd be like ready to push the paralytics and get the tube ready to go.
Okay.
Yeah.
So you guys are
While I'm suctioning it as aggressively as possible for those secretions.
I mean, I think I would probably, we didn't talk about what tube we have loaded, but I think we know this guy's, I would have already like probably had a 6.5, I think, just to like have it in the middle ground. And I would probably try to see like, yeah, I would, before I push the rock or anything, I would really try to get the tube in past the cords. I don't know if we're at that place yet.
sure. Okay.
It's also one of those, sorry to interrupt, but it's one of those things where their breathing
By the
is
way, he's just
hurting
like
you.
this right now, like doing all of this.
Yeah. They're breathing and you're like, stop breathing.
Well, exactly, 'cause it's, now the camera's, the condensation on the camera from his
makes it worse.
exhalation, he's having
Yeah.
like laryngospasms, he's having, his vocal cords are closing and opening, and it's just like sometimes at this point too, I'm not hasty, but I'm pushing the paralytic maybe before getting it past the cords because I can't do it with it on board. So I'm
I think that's
considering
fair.
that.
And also
'Cause
just
at
like
this
how
point, I've
much
made
they're
the
opening their
decision.
mouth is like limited, even when on ketamine, like
Yeah.
it just doesn't open as much.
Yeah.
So
And the rock or eat, whatever, it's going to take 30 seconds, or that's going to feel like a real long time. So,
Okay. Do you want to push a paralytic right now or no?
yes.
Okay. You giving rock or sucks?
rock.
Yeah, I'm giving rock.
Okay. The rock is in.
It's gonna take longer.
I feel for the scalpel in my
Don't
pocket.
worry about it. It's going to Alex. So the big exhale
God.
now. So the rock has been pushed. He's now no longer breathing spontaneously. You're trying to put the tube in. You're just using the rigid stylet and the 6.5 tube?
Well, I had thoughts about that actually.
Okay. All right.
So
Not on board.
Too late. Paralyzed every time for your thoughts.
I actually signed out a long time ago.
Someone just pushed the rock on me and now I'm in this position.
well, if the rock's
That's
on board
happened
already,
before.
then I don't have a choice. I'm gonna go for it. But okay, is the rock given?
The rock's in.
All right.
It's too late.
Let's go.
What are you using? Are you using a rigid stylet with a tube? Are you using bougie? What are you driving through the cords? Or trying to?
If I have a poor view, even with the video, I'm definitely going rigid stylet. I mean, I've always had poor not poor outcomes, but kind of bad luck with trying to pass a bougie
I totally
with
agree.
a video. Yeah,
Mm.
Just does not curve as much.
exactly.
Yeah.
What'd you get?
I got a 6.
Out of 6.
I think
You
it
see-
looks like a 12.
Yeah, it's 12.
You see the cords up there in the distance, antagonizingly staring right at you. Every time that you're trying to like get the tube up there, it's just like kind of hitting the arytenoids. It's just like bouncing kind of right there, and you just can't seem to get it up and maneuvered into that position with a 6.5 tube. Right now, he is satting 89%. He's been apneic now for about 30 seconds, so you got him pretty quickly, but all things being told, and the blood pressure recycled,
We're all
and
sighing.
it's
I know.
100 over 70.
Okay.
What do you want to do, Mary?
I mean, I think at this point, if he's 89, he's probably truly 80 or 79. So I would probably bag him. I'd like reassess, take the glide scope out, maybe put an LMA in, and just try to bag him, and just make a plan. Like, okay, do I go back in? Do I try DL? Do I go with a bougie? I'd probably try both those things. If I was able to bag him up, I'd say, okay, just give me a DL. And let me see what I can do with a bougie and a DL. I think that's probably what I would go for. I think it's too hard when they're paralyzed. You can't sit them up and now do a nasotracheal. so now you're stuck.
can't, like,
You have to
weekend at
make this
Bernie's
work.
it. It's just not- it doesn't
Yeah.
work
Just have
out that
everyone
way.
hold them and then. So I would probably just decide whether I was going to do something different. Like I think the thing that you get in here is you try to do the same exact thing, and that is not the right thing to do. So usually to change it up a little bit, either with your what you're going to use to intubate or your mode, I would probably do that thing. So I think I would probably go to DL with a bougie.
Okay. Go ahead and give a roll. So you're putting the LMA in.
7.
Okay. Man. Got the LMA in. I'm going to give you a +2 on that just for using the LMA rather than just bagging him in general, right? And you're able to LMA him really great. He's ventilating pretty well. You realize how precarious your situation is after 30 minutes of talking about it with everybody, and so you keep bagging him, and you're not going to rush. He's on his rock on board. He's still giving you that like I'm terrified face. And you're just like looking down at him, bagging him through the LMA.
Give him more ketamine in the meantime.
Redose him some ketamine. He comes back up to about 94%. Repeat vitals. His heart rate's 90. His blood pressure recycles 110/70.
All right, let's take a look.
All right, give it a roll.
I thought that roll was the intubation roll. 7.
7. Okay, so you get in there with a Mac 4. You got some pretty good guns on you, but this guy also is a little hard to maneuver. And you had him in this 45-degree position. It was really optimized for your first plan on VL, so he doesn't have a ramp, he doesn't have any of the other cool stuff. So you have like a grade 3 view, absolute best when you have RT given like the people's elbow to the top of the trachea to really try to push it down into view for you.
Okay. I think that's enough for a bougie.
Yeah.
So I would just scoot a bougie in there and see how we do.
All right.
Have them load a 6.5 to it.
8
Nice.
+2.
We got it. No, -5 for you. You get the bougie through. You got a bougie through the cords. You see it definitely bounce on the bottom of the arytenoids, and it feels like it goes up. You feel rings, or you're telling yourself you feel rings.
It's actually going through. It's not stuck by whatever's.
It looks like it's gone through. EJ, what tube are you putting on there?
I mean, plastic is better than no plastic, so I say 6.5.
Okay.
Yeah.
Give it a roll.
All right. 3.
So you get the tube, you're trying 6.5. It goes through the arytenoids, it looks like, and then it's just, you start feeling some resistance. But it's like the balloon is almost all the way through the arytenoid cartilage for what you can see, but it feels a little taut. What do you want to do?
Swap it out for a 6.
Yeah, I would probably just
That's the lowest you can
downsize.
go.
Yeah, we're in the right place. Just see if we can get to a 6. Yeah.
You quickly pull it out. He's satting about 90% now. His heart rate is about 70, down from 90.
Don't like that.
You throw a 6.0 tube on. Alex looking like he's really upset that he's in this situation. Give a roll.
He didn't want to get rocked in the first place.
8.
I know.
8. So you do the same thing. You feel it. It seems to go a little bit further, but there's resistance still, and you feel some resistance. And you're not sure if you just kind of give it the old like quick shove, like maybe it'll go through, but there's a good amount of give to it.
Okay.
What do you guys want to do?
What's the vital signs while this tube is stuck?
He's satting now at 89%. Again, his pulse is coming down. It's in the 70s. The blood pressure machine is just whirring that very ominous in the background, waiting for you.
Yeah.
Okay.
Yeah.
He's like, guys, I wanted to do it awake. I wanted to discharge the patient.
Why am I not in charge?
First blood gas.
Yeah. I'll tell you during the debrief what I think I would have done with that airway, but
Just a total turncoat on the team.
oh, sorry guys. But I mean, it may not have worked.
Well, this one didn't clearly
Yeah,
work.
so if the 6.0 is stuck and there's no give, I would try to the best of my abilities to try to kind of squeeze that in there. But
I would too.
If he's at 89% and continuously desatting while the tube is past the arytenoids and I'm somewhere in the trachea, I would try giving him a breath or two at least to get him up before I think of my next plan of how
You're saying you would pull the bougie out?
I think so. I mean,
You have to.
yeah,
Yeah.
you have
You
to.
can't bag over.
I know that's what I'm saying. So that because that's I feel like that's the big
you
point.
really got, I feel like pulling the bougie out piece. But I see what you're saying. I think that would be very hard to tell just by like looking at it. You'd have to feel like, yes, we are not going to blow up the balloon. We're going to, but I don't think I would do that. Sorry.
No, it's fine. Or the other option is go back to an LMA to bag him back up.
Yeah. What are you gonna do? You got to make a decision.
I mean, the safer
is
thing
that
would be,
airway, though?
the
Yeah,
safer
especially
thing.
because you had to DL it.
Yeah, it'd be so tough to try to get a. Actually,
you
you can
can't
leave
get-
the bougie in there and
Right.
fit the LMA over it and bag over that. And
So if I
that's
at
what
this
would
point
do.
think I needed to oxygenate him,
Yeah.
I would
Yeah.
That's
pull
what I
off
would
the
do.
ET
Yeah.
tube, keep the
Keep the
bougie in there,
yes. There we go.
bag via the LMA or via just a bag
We knew
valve
we could
mask.
do
Yeah.
before, Give him some, and then look at his, just reassess with his vital signs.
At this point too, I would then once we back him back up, use the video with the bougie that's already still sitting beneath the cords to get a confirmatory view, and then see if I can visualize anything. And then when you railroad it again, try to twist it, try to manipulate, and be like a little bit comfortable shoving that thing through, because
I would definitely try.
my
shoving
options
it a
are
little
going
bit.
to be cutting the neck anyway. So
Yeah.
a little bit of tracheal
Yeah.
trauma
Edema.
is less than a
Yeah.
complete
Yeah,
severed.
I mean, the only
trauma.
problem is if you're thinking you're going to have to go down, you're going to have to pull the bougie out anyway, because you can't put a 5.5 over a bougie. So you're kind of stuck, right, with like, and I wonder if you would put the 6.0 there just to keep your space, pull out the bougie and put in something smaller. Like, is there a way to put like a wire
Like
through?
an exchange catheter, maybe.
Yeah,
Those are
or
a
if
little
if
smaller.
all you have is like a triple lumen kit, I would probably take it out, take the wire out, put the wire in while we're open, and just
How you
try
getting
to
the wire in?
Well, you put a 6 and O over the bougie, so
This
you
is
know
getting-
the bougie's
okay.
there. You know the tube is there.
just says it all in this moment. He's just like, we're putting wires in now? Like, how did we get here?
I mean,
You made this.
I would probably try something like that, because you just know you're going to have to downsize one more time, and I would, like, while you're looking at it, try to see if you can keep a wire and then take out the 6.0 and put a 5.5 over the wire. I don't know. I might give that a shot.
You call out to the nurse, give me a central line kit, and they're like, oh, we got the tube, perfect. We're doing the
mouth.
and so they're getting you one. So right now, are you doing, the vitals are what they were, are you doing give a quick push attempt, or are you pulling out LMA with the bougie still in the airway?
If he's desatting, I think I would leave the bougie in and then still get the LMA in and bag him back up before I do anything.
Wonderful. He ventilates really easily with the LMA.
Yeah.
You get him back to essentially where he was. His blood pressure now is like 107 over 60. Heart rate is in the 80s, satting 92 to 93%. What are we doing? You just admit him like that, you know?
Yeah,
Just
I mean, that rock's going to wear off eventually.
Yeah.
the rock's going to wear
Yeah.
out. Yeah. I mean, I think the decision now is like,
You have this churning feeling in your stomach like this is your last attempt.
yes. I
Yeah.
mean, I think that's obviously true, that you have to, at this time, whatever you do, you also have to be ready to cut. And you just decide whether to cut already.
Yeah.
I think that's kind of like, yes, I can get a 5.5 in somehow. I think that's what I would try with a regular, maybe I would just try with a regular, I don't know. In terms of like, because you can't put in a 5.5 over a bougie, I might take the risk to take the bougie out while I'm looking at the cords and put a 5.5 at the grade 3. I don't know what else option
I
we
mean,
have.
if you had a grade 3 with a DL, you could, CMAC video and then bougie there, because then you don't have that huge angle to get past, and then you could, or maybe just direct with your 5.0 at that point.
Guys gonna make a call.
I'm going to go one more time with the regular and just look at it and like have them loaded my tube and
And we haven't reached the point where we're not being able to oxygenate and or ventilate,
Right.
So we're not even like to that threshold.
right. That's why I think we did one. This is
Yeah.
the last shot, but I think the best shot is. I mean, would you agree? I think it's the smallest tube. But
we're still on the central line
We have to do
kit?
it of a. No, I think we have to decide how we're going to get that small tube in. Whether you go with the stylet or whether you try to have a guide wire of some sort, whether it's the bougie or something else.
Is that retrograde you're talking about?
It'd be a nightmare doing a retrograde intubation on a 380-pound patient.
This whole
With-
thing's
with
a nightmare.
subglottic stenosis.
Oh my God.
I just love the energy level. It's so different.
So heavy.
Because you're just so upset.
I think we just got to commit.
Our
God.
job is hard.
It's true.
It is.
All right. Got to commit. Let's do it. What are we doing?
So at this point right now, we've got a bougie, past
Coming
the
out
cord,
the side
and
of the mouth.
LMA,
Okay.
and LMA there.
LMA's in.
Craig just doesn't want to commit.
Yeah.
No, I'm pulling that. I'm going to VL, and
Okay.
I'm going to jam something through there.
You're gonna go VL or DL?
VL. Just because I already know where the bougie is. I would just want the VL to get a little bit of a better view, because it sounds like the best view we've gotten has been,
With DL.
well, that VL, we just couldn't get the thing. We could
Yeah.
see it, we just couldn't get the stylet, or the rigid stylet anterior enough.
But are you hyperangulated?
But either
or
way,
CMAC?
regardless, the view is less important for me right now, because all I'm
Yeah.
trying to do is physically
Push it.
push
tube.
this tube past whatever is obstructing it. That's the crux of our problem right now.
Yeah.
And so
Well-
what the view is less important than what's your maneuver to get that tube past the obstruction, which is
So you're going
at this
with the
point
6-0
twisting
again.
and blunt force.
You're gonna go with the
5.
6-0 over the
Whatever
bougie again?
whatever the tightest I can fit over that.
Or the bougie, yeah.
Yeah,
Oh, okay.
bougie.
So you're gonna try the 6-0 again and just try to push harder.
Because I mean, if you think about it, that bougie, whatever the width of the actual ET tube is, not that much more. If you have like a tight ET tube over that bougie, the additional width of the ET tube on top of the bougie is not that much. I feel like I should be able to just muscle that through, even if it's scarred tissue. I should be able to muscle that through.
Okay. I don't know if I would do that, but I feel like the 6-0 is like.
Let me roll
Anyway.
the dice.
Go for it. He's Everyone's okay with him muscling it through?
No one's okay with any of this. I got a 3.
This is all terrible. You got a 3?
Yeah.
He's dead.
Where's the grandpa?
We gotta cut.
All right, so you pull out, take a look in there. View's a little bit worse than before. You see
Of course it is. Never gonna get
more
better.
edema around the entry to the airway at this point. You got that 6-0. You feel that little bit of give still. You're going to muscle it through. You have a big push. It doesn't feel good. Kind of like the nurses kind of look at your forearm, kind of like hits the bed a little bit, and it feels like it went somewhere.
I remember this case from residency.
You go ahead and you pull out the bougie. You hook them up. They inflate the cuff. You get color change. You look over at the vital signs, though now he's like heart rate's in the 50s. His SAT is like 78. His blood pressure is like aggressively cycling.
And you never had breast sounds before, so you certainly don't have them now.
You can now. You do have an end-tidal CO2 tracing though, which is pretty great. It's just maxed out. That's just, but it's positive. The number is like greater than the upper limit on the monitor.
Yeah. Well, I think while you're confirming the tube is in, you assume it's in, and you bag and you use your over the stomach. You use every other tube, tool you have to see if it's in. See if you popped a pneumo or a trach or something. But yeah, I guess I would just bag and presume it's in.
And then I'm setting up because I'm worried.
Setting up
to
for
do
your
a
Craig while you get an
surgical
X-ray to
Yeah.
confirm, right?
Yeah.
I mean,
And he's about to code.
you get feeling for
So,
crepitus. I mean, this is like a real quick assessment. I think
Yes.
at this point, you don't have much time.
Got no crepitus. It's really hard to tell if you have a pulse. It seems like he's bradying down.
Yeah.
You guys start compressions because you think that like, hey, we can't feel a pulse. It's not really reliable. What do you want to give him during the arrest? It looks like it's PEA, a Brady PEA arrest.
Giving him epi.
Okay.
Giving him
I'm
bicarb.
giving him bicarb, yeah.
Yeah.
A couple things of bicarb. And then we're doing a Craig while we're coding,
Yeah.
I think.
All right. So you give him some epi, you give him some bicarb. To be honest, the pulse ox starts to like come up a little
Sweet.
bit after you give all the bicarb and you're hyperventilating him. And actually you get ROSC just as you've like got ready to cut the neck, essentially. Everyone's ready to go. You get a confirmatory x-ray and it's like the funniest thing in the world because it's like this little dangler hanging up in there, but the lungs are inflated. There's no obvious pneumo. And as fast as you possibly can, you dispo that patient to the ICU immediately. But just for giggles, you get a CT on the way up of the neck, and this is what it looks like. So he has, at the smallest area, is a 3 millimeter airway that is approximately 7.5 centimeters below the epiglottis. So it's essentially just below the first like rib space and clavicle. So the subglottic stenosis is almost in the chest, essentially. You can
how we
see
got
like
that
the
tube
level
in
here on the side.
I'm not sure that's physically possible.
Yeah. Like,
Oh,
Yeah.
jeez. Yeah,
That's
not
what he
sure
ends up
that's
looking
That's
possible.
incredible.
yeah. That was a
That
really
sounds like
tense
magic.
case.
I mean, that's
guys
the
did-
nightmare
Yeah,
airway.
it's like the nightmare airway,
Yeah.
right? And I mean,
Yeah.
like you guys worked through like the entire. Like I can't imagine any other thing that you. I don't know if there's an airway technique you guys didn't discuss in that entire
Including
process.
novel ones.
Yeah.
Including, yeah.
And you know, like,
All right,
just-
so hear me out. This would have been my approach.
Let's hear it.
All right, let's hear it.
So
Yeah.
I'm in there with video. This is before Rock, by the way.
Okay.
He's-
Ketamine, and remember, he's
Noted,
looking
noted.
terrible.
yeah. So he's got ketamine on board. He's sedated. I get video in there, and I don't have a great view because he's too anterior. At that point, I think I would try fiber optic, but with someone holding the video to retract the tongue, and because the nasotracheal pathway will give you a better angle, a curvature into the airway, I think I would attempt that before going just the paralysis route.
So you would move around to the front of the bed
And have someone else hold
it.
the glide scope.
and
or
then
whatever
use it like
video.
kind of like a drivable, well, not necessarily a drivable bougie because you're still doing nasopharyngeal. You're
It
going.
would be a drivable bougie. I
It's
would have
kind of
like
like
the
a
smallest
drivable-
caliber tube that I could load onto that thing.
I think which we had
go-
already done.
Yeah.
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 Double VL technique.
Yeah.
You can also do it from the head of the bed too. Like if you're doing, I've never done it nasopharyngally from the head of the bed, but the oral pharynx you can still
Yeah.
maneuver like a drivable bougie.
Yeah, at that point, if you have space, you could do it just from the oropharynx.
Yeah.
Maybe.
I mean, in terms of this airway, like you guys prepped for the physiologic challenge as well. You know, like putting them on BiPAP as quickly as possible, making sure, like with the ketamine-only breathing intubation, trying to preserve those respirations as long as possible. Really set everything up how you could attempt to do it. In real life, this guy got ultimately transferred to a specialist center there's apparently this very special type of ENT surgeon that can get in with an airway that far down to do a tracheal resection and bring the two pieces together. Wow. And we think that maybe he didn't even have asthma, it's just that he's had this for so long, and every time he got like a URI, his airway closed up, and like, oh, it's just that asthma again, and he just got unlucky today.
ENT still.
Got worse today.
I was going to say, that seems like almost cardiothoracic.
Yeah.
Good
Except
point.
they don't do airways.
Well, I mean, great job, guys. This is a very somber note for a case that was pretty good. I mean, it's
This is
truly a nightmare situation.
had.
Yeah, this was me and Herzig. It was at Sign Out, and we were like, look, he was like, oh yeah, take a look at this guy. Here you go, on out. And I was like,
We should have never intubated.
Oh my god. Yeah.
Yeah, that's the other question.
I mean,
that's
I
why
think
this
it
case
is.
is so hard.
Yeah, we ended up not intubating him in real life,
Yeah.
and it was like a lot of praying, and every 5 minutes, like going back.
Yeah, I
to
mean, I
the
saw that
room.
CT. There was no tube there.
Yeah. And that was the other thing, the decision to get more advanced imaging like really early on when he like looked great. So we like laid him down in the bed in the room for like 15 minutes just to see what would happen before sending him over to scanner. And he hung out and tolerated it.
it's just hard
We
to
also
do.
asked for a lateral neck x-ray just for, whatever,
I mean,
and
wow.
we just got shut down.
People
But-
swallow things. You never
That's
know.
true.
Yeah. Well, great job, guys.
Sort of. That was rough.
Oh,
All right.
Man, that was trying to end on a happy note. The guy didn't die.
Yeah, I guess that's true.
It's true.
That
Forever,
highlights
too.
the hard part about this job. Is like when they come in dead, the job is almost easier.
Easy.
Yeah.
When they come in and you have the ability with your decisions to potentially kill them, this job becomes much more difficult.
Yeah, incredibly hard.
Especially when you're like trying to avert disaster later, where you have this like window where you're like, if I intervene now, this will be as safe as it can be. If I send him up and he decompensates, he's gonna die for sure.
Right. But there's also that trajectory
and then
where
this other thing
nothing-
where like we could have just temporized him.
Wow, Britt, that was an intense case.
That was really intense. That was super, super challenging.
Yeah, I thought it would be good for us to start with a little summary of what happened.
Yeah, I think that would be helpful.
It's pretty rare that we do stuff where we actually see clinicians explaining their clinical reasoning in real time with the actual uncertainty introduced by the dice
Yes.
that we experience on every shift. We don't know how things are going to go, how things are going to play out. So let's start from a common ground. So this
Summary.
was a case about a older gentleman who maybe didn't have the best airway anatomy, overweight, no neck, came in some respiratory distress. Initially, everyone thought it was asthma because he has a history of asthma, but it turns out it was likely because he had subglottic stenosis that was getting aggravated by whatever URI he had going on. He came in, he was acidotic, he was hypercapnic, that progressed, and the team ultimately chose to place a definitive airway out of concern for the patient's clinical course. So this was both an anatomically and physiologically difficult intubation. And I'll be honest, we pushed the team towards intubation
Yes.
throughout this case because
Yes.
we wanted to have this discussion.
Right. And I mean, that's the hard part of this case, right? Is deciding when to intubate and how to intubate. Because you have someone who looks okay. And so while they're looking okay, you're doing your interventions, you're putting him on BiPAP. Yes, he's getting more acidotic, but do you take the airway now when you can be in as controlled as possible? Or do you see if you can push it a little bit longer, see if those interventions and the steroids really start to kick in and maybe get away from the intubation? Well, obviously they needed to intubate in this case, and I think they did a fantastic job running through how they would do it, how they would set up.
Yeah, and I think it's really important to emphasize again, in the way we played this case out, we pushed people towards that option. In real life, this patient did not get intubated. And we could talk about for hours and hours on end how to approach these physiologically difficult intubations. But the idea of BiPAP not being a bridge to nowhere, right? Its idea is it's either a bridge to recovery, they get off of it, or as a bridge to definitive airway placement, to intubation, or as a bridge to an immediate reassessment with some preset parameters. And that's kind of where they went in this case, but tweaking the BiPAP settings,
Yes.
reassessing the patient, and other alternative therapies like racemic epi or things to, if you knew that's what the problem was, to maybe help improve ventilation, might be another strategy here. We're not going to go into all the details of the decision to intubate, but it's very nuanced.
I think, personally, maybe if I was in front of this patient, obviously you were pushing them to intubate. I think I would have messed with the BiPAP settings a little bit more. We still don't know if this is asthma. It could have been. And we know that his CO2 is pretty high, and that's what's kind of driving our problem here. I probably would have made a setting for the E to I ratio a little longer so he could have some more expiration and maybe blow off some of that CO2. Again, this is not the person you set the BiPAP and leave. I am staying there watching him because I don't love when you walk back into the room that he's sleeping on BiPAP with his respiratory issues. He was easily arousable, but still, I think I'd mess with the settings a little bit and watch him very carefully and repeat a VBG.
Yeah, I think that's a really important point. And the other thing that we have to remember with BiPAP, where the actual inspiration time and expiration time is controlled by the conscious patient, is the coaching component too. This is someone you're at the bedside the entire time, working them through it, especially in those like critical few 15, 20 minutes. They did a reassessment after like an hour, a whole strategy there. But what I really want to talk about is the actual strategy to the anatomically challenging intubation. How would you have intubated this patient?
They talk about a lot of fancy techniques and fiber optics and all these things. I think definitely the awake intubation is the way to go, because on top of the anatomical stuff, we have to think about the physiological issues and really that he's just so acidotic. So we do not want to have any apneic time if we can prevent it. So the awake intubation definitely would have done that. I'm not super comfortable with the fiber optic, so that's probably not the first thing or even maybe my backup in this situation, because I just don't feel that great with it, to be completely honest. And I think what's going to increase your first pass success is doing what you know. If that's DL, do it. If that's video, which for me it's video, that's what I'm reaching for. The only thing that I think I might have grabbed on top of the bougie, the regular adult bougie, is a pediatric bougie. Because we talk a lot about we're ready for a lot of stenosis down there. We're ready for a very small airway. If I have a pediatric bougie, I can use a smaller tube, like even a 5.0, and just start there.
Yeah, totally. I think what's really awesome about how this case played out, it's really easy to be on a podcast, on a video, and say, I would do an awake fiber optic intubation.
All the fancy things.
It's an area of interest of mine. I've done well over 50 in patients, and still, I don't feel as comfortable doing that technique as I would just doing DL, because I've done over at this point, hundreds and hundreds of DL intubations. It's how I was trained at my residency program. So I thought it was really great that we saw that play out with our own team of clinicians and gravitating towards the thing that they felt was the best chance that they had at first pass success. This is like a textbook case for doing an awake intubation.
Totally.
Their choice in the real moment was a ketamine-only breathing intubation with video laryngoscopy, which still tries to maximize the amount of ventilation the patient has, minimize apneic time, so the goals align, technique's a little bit different. And I totally agree. Finding something smaller to navigate through the cords would have been huge here. We had them improvising, and we heard Mary Sheffers talk a little bit about like finding a wire at the hospital that they all work at. Actually, there wasn't a pediatric bougie when this case happened, so I think that's where that thought process came from. But exactly right. Like, what's the smallest piece of plastic that I can put between the cords, put a smaller tube over to avoid that roadblock? I think Emily Johnson also mentioned in the case an airway exchange catheter, sometimes called a Cook catheter. Those are cool because they're like a bougie you can ventilate through. Almost every hospital has one. Anesthesia definitely has one. You can get them in your emergency department. And
I think Alex did a really great job of kind of explaining a little bit of a different approach. And I really, I think key here is explaining to your team what you're about to do, because we're doing this in a more controlled setting, right? We're taking this airway before he's totally crashing. And so talking to your team like, hey, I'm going to use video, and then I'm going to ask you to hold the blade so that I can move from the front of the bed to the back of the bed. All of that, you're doing in your head, but you really, communicate with your team so they know where you're going, and that will also set you up for success.
Absolutely. For some clarity, for those at home who might not be familiar with this technique, Alex Lee was talking about video-assisted fiber optic intubation, sometimes called VAFI. I think we jokingly called it double VL in the video.
Which works too.
Which works, and it's basically the idea is we're uncomfortable with fiber optic. Why not leverage video laryngoscopy, a skill set we're very comfortable with, and then utilize the increased mobility, flexibility, and tube delivery system of a fiber optic scope to kind of get back in there, see what's going on. It's something that I believe is the gold standard for doing a fiber optic intubation, even in awake patients. This is how I do it. It's a really easy skill to learn, and we'll do some more teaching on that in the future.
And I mean, we know that this guy has excessive soft tissue, and so just even having somebody with the blade in there lifting everything up, is going to help pass that tube so much.
Yeah, absolutely. Well, we hope you guys enjoyed this novel session. We really think it's important not just to present educational information, the facts, the figures, the milligrams, but the clinical reasoning and the thought process behind what we do every day. It's really easy to get up here and talk about a case when you know the outcome. I want to give a huge shout out to all the faculty. It's really hard to come to this space and do something totally off the wall. You have no idea what you're walking into. It's the same level of stress as kind of seeing a critically ill patient on shift. And I thought it was cool that the emotional tone of a lot of the interview was pretty somber. It was people kind of feeling that stress.
Thank you so much for your vulnerability and really just walking us through how really smart people think.
Yeah. So when are we meeting again, Britt?
All right. So our next grand round is back to urgent care. Urgent care grand rounds on June 5th.
Awesome. Thank you guys for spending the evening with us. We'll hang around in the chat a little bit longer if you have any other lingering questions that we normally answer at the end. Don't forget to like, subscribe, hit the little bell so you're alerted whenever we do these, and let us know if you want to see more content like this. Thought it was fun. The nerd in me who loves D&D had a great time playing it, so if you guys like seeing it, we'll keep making it. Have a great night.
See ya.